Thank you, Dr. James Barone, for talking today about resident readiness for practice. You were a program director for many years, and I'm curious to hear how you saw resident resi- re- curious how you saw residents in their preparedness for practice over the years. Did you notice a change between when you first started as a program director teaching surgery residents and your final years?
Yes, I did. Yeah, I did. I think the residents in the early days were a little more ready to practice. Not as many of them chose to take fellowships. And I think they just had a little more confidence in themselves than the more recent year residents that I can recall.
Mm-hmm. And what changed over time, do you think, that affected that confidence or their actual preparedness?
Well, I think there were a couple of things. The easiest one to grasp, of course, is the work hours change. And I don't know, it's very difficult to quantify because if you read the literature on what has been written about the impact of work hours changes, it's kind of mixed, and there are some people who don't think it's made too much difference, at least in the amount of work that the residents seem to be able to do, cases and everything. But I think just can't take what amounts to 20% of the work out and expect the same results. In other words, if people were working 100 hours a week and now they're only working 80, somehow they've lost 20% of what they used to do. And even going to get worse with the first year people now only doing 16 hours at a time or whatever they're doing. The other thing I think that's happened over the course of a lot longer period of time is there's been a gradual change in the amount of responsibility that residents have been able to be given. I think it's partially driven by medical legal issues, and it's also driven by possibly consumer outcry and who's doing my case. And I don't know, maybe there's been a change in the way attending physicians look at residents too. But I can tell you that there was a time when residents operated by themselves. Chief residents took junior residents, and that doesn't happen too much anymore. I don't know of any programs these days where can operate by themselves. And I think if you've never operated by yourself and now you're in practice in July after you graduated and you're starting to operate by yourself, it's different. And I think it promotes uncertainty, and I think some studies of residents have certainly shown that the confidence levels of graduates and people who are still not quite graduates is lower than it used to be.
Yeah, so you're talking about resident autonomy. In other words, people running the
Yes,
case
exactly.
themselves, making decisions in the hospital. Um, and so are
And by the
those.
way, not just in the operating room either, but managing the case. I think there's been a big shift in the way cases are run these days, where even the post-op care is much more tightly supervised by the attendings. And I don't think that you can just say, well, let them do whatever they want. But there are ways to supervise without being oppressive. And I don't know whether that medium has been found. I think that some of the supervision may be a bit too much, and therefore the residents don't get to make decisions
Mhm,
about when to start feeding a patient
mhm.
or when to take them back to the OR, when to do anything. They have to check with their attending for everything, uh, um, and I think it's actually difficult to expect people to do it this way, and then just okay, after 5 years and now they're in practice by themselves, suddenly they've got this skill to manage the patients and the confidence to make decisions. Uh, I mean, we've all, when we graduated, I think, and went into practice, I think everyone had a lot of uncertainty and anxiety about, finally being responsible. But it just, I don't know, maybe it seemed easier back back in the older days. But and of course, I could be completely wrong about this too. I don't have data because I think this is a very hard thing to research.
Sure.
And I think also the when you do surveys and say to like you get a group of residents and say, well, how do you feel about going to practice? I don't know whether the way they answer is really quite as accurate as they feel or not, because as you know, surveys can be highly influenced by the way you ask a question.
Sure, sure. And if we presume that there is a difference between their preparedness now and say 20, 30 years ago, what do you think? What changes do you think could be made within the training programs to encourage autonomy and affect
Well,
preparedness?
that's a very tough question. Within training programs, I don't know honestly how you can change it. You've got the constraints of the time, and even if you cheat the time a little bit, and so they work 85 or 90 hours a week, and you just tell them to lie, which I think happens. I hate to tell you this, but it's true. I'm not sure that that's going to completely solve the problem, because you still have the issue of the lack of autonomy. And I don't know how you get people to change. I think that, if you're an attending physician in the middle of your career in a teaching hospital and you've been kind of doing it the same way for a while, it's pretty hard to go to those people and say, well, now I want you to start as of this July to give the residents more space and back off and don't get so involved with the cases. And they're going to look at you and say, yeah, but my malpractice insurance premium is already sky high and I don't want to get in any more trouble. And I think, how do you fix that? I don't know. And then you get people who write things that say, well, don't forget to ask your surgeon if he's really going to be doing the case and all that sort of thing. And, and then I don't know how people expect surgeons to be suddenly gifted with the ability to make decisions in the OR or outside the OR if they've never independently done it before. What about I don't know how you can do it as a training program.
What about changing the length of training or the transition to practice fellowship? There are some efforts. I think it was the American College of Surgeons has a transition to practice fellowship, which seems to imply.
Yes, I'm aware of that. Yeah, that you need it. Well, let's take the questions one at a time. Lengthening the training is really going to be tough. I mean, you start talking about the average debt of a medical student who graduates is something like $160,000, or it could be even much higher. And that's just the average. There are many people who are in the 200,000s. And you tell them now you got to defer paying that off for while you work for $60,000 or whatever residents are making these days, and you extend the training for another year, when all other forces are saying we got to shorten this. We got to take a year off medical school or maybe a year off of college and figure out how to get surgeons out there without spending 5 years and then 2 years in a fellowship or whatever. And so lengthening the program is not very appealing, and I don't really know how that's going to work. By the way, the other thing that lengthening the program does that people don't always quite get is that let's say you have 4 residents categorical per year, and they go for 5 years, and that's that. If you increase it another year, it's like adding 4 new residents to a 5-year program. If they're going to be another year, there are going to be people around wanting to do cases, and you have the same amount of cases as you did when you had a 5-year program. Well, that math isn't going to work. You can't just expand, the number of people and keep the amount of work the same. It's not going to work. And the transition to practice fellowships.
Well, I'm sorry.
That's a really
on that previous note. What about earlier differentiation and, in other words, getting out the people in 1 or 2, 3 years who are not going to be general surgeons and concentrating cases for
yes, well, that I've always sort of not been for that, but lately I've changed my mind. I think that's going to happen. Here's a problem, though. I don't think the American Board of Surgery is ready to do this. I know they've done it in a few things, like vascular now, and plastics has always been, it's possible to do 3 years of general surgery and then go straight to plastics. But if you're going to mandate that, that people have to, if they want to be general surgeons, they have to pass the general surgery boards first, and then whatever else they're going to do, then they're going to have to take their boards again, and I'm not sure how that's going to work. And the other thing is, what if you decide, let's say you decide you want to fast track as the vascular surgeon, and then you start doing it and say, I really don't want to do this, I think I'll just do general surgery. Then what happens? You've only done a few years of general surgery, you're really not qualified. Earlier differentiation means that people have to make choices even earlier than they did in the past. Mm-hmm. And I think one of the issues there has been that you have third-year medical students right now deciding about a career in, say, urology, and they might have had a week or 2 weeks of urology, or a week or 2 weeks of orthopedics. Yeah, they can take an elective and all that, but it's different when you get into training. Right. And I think the same thing is happening in general surgery. People are forced to make a decision really early in medical school. And by the way, that's a problem with shortening medical school to 3 years. You're going to have to make these people decide what they want to do even earlier. And then I think that accounts for some of the attrition rates that you see in general surgery, where it's 20 or 25% of the residents, one way or the other, drop out or are forced out because they never really knew what they were getting into in the first place. And once they start into the training, they realize, oh, this isn't for me. But, it's hard then. So you're going to take people and then say, not only you have to decide to be a general surgeon right off the bat, but now I want you to tell me before you even start that you're going to be, a vascular surgeon or a whatever, minimally invasive or however you're going to do it. That's going to be hard. But, at least it would do two things. It would shorten the process, which I don't think anyone would object to. And it would also, some cases, for, like if you're going into plastic surgery, why do you need to do Whipples? Right. You're never going to do one, and you're just taking them away, and they're relatively rare anyway in a lot of programs. So, I guess on balance, I would say I probably do favor shortening things up, but it's not going to be without problems. Sure. Because you're going to have issues of people who realize they don't want to be plastic surgeons or whatever.
So I have another transition question. This may be my perception, and I'd be curious for your perception. It seemed to me that when people went into practice 20 years ago, they were joining a practice where there was some mentorship and some guidance from a senior partner, and a junior partner had a bit of but someone to lean on when they went into practice, and I wondered if the model now that people are largely taking jobs where they are hospital employed, if it has that same sense of partnership and mentorship that I believed existed before. Is that accurate to say there was a sense?
Yes. Yeah, I think you're right. The thing is, though, many years ago, lots of people went into solo practice, and I think that's pretty much dead. I don't see how any graduate, especially if you have debt, can just go someplace and with absolutely no help, set up an office, get their malpractice insurance going, hire people, and everything, on their own. It's almost impossible. Sure. So I think that when you join a hospital-based group, which I think is what you're referring to, there certainly will be more senior people. And since there's no economic competition really amongst those people, although many hospital-based groups are set up on merit-based bonuses and things, like if you do more work, you get paid more, kind of like the private practice model. The busier guys are making more of an income. So, but I think in general, there should be mentors available in that setting, because you will have a diverse group of people, and that's good. I think that one of the ways to ease that transition from never having any autonomy to getting some is obviously to have people around that you can ask a question in the middle of the night, or call somebody in to help you with a case if it's too much for you to do, or you're not sure what to do. That is helpful. And I think that is possibly the salvation of the whole process, is that, as the solo practitioner fades into oblivion, there will be more of a hierarchy of people to talk to. I think the only
Well,
place
that's
that's not going to work is in a rural setting where there aren't enough surgeons around to do that,
right.
and then you're going to have guys are going to be on their own.
Right. Well,
There's not
that
much
actually
else they
was
can do.
that was reassuring to me. My belief was that the sort of changing models was going to leave us with less sort of mentorship and help. But it
Well, I
sounds
mean,
like
again, I don't have all the answers, but some of the hospital-based groups I'm familiar with do work that way, where there are more senior people.
good.
And these are usually people who've been in practice for several years, or even 20 years, and the hospital buys out their practice, and then they take it for the security and the slight lifestyle changes that working for somebody brings, but they're still there, and they're still more
Sure.
senior, and
Okay.
then junior people come into the to the group, and they at least can, I think they can access the mentors. I did want to comment on the transition to practice
Yeah.
fellowship though too, and I think it's a nice idea, but if I read about it correctly, there really are very few of them in existence, and I haven't seen too much about it since it was proposed. I think it's happening, and I think I read somewhere that there are some people doing it, but I think that it would be interesting to know the numbers. Like, is it even double figures? My understanding was there weren't very many hospitals or programs doing this. Under 10 was my understanding, and so I don't know that that's going to make a huge dent when you figure there are more than 1,000 chief residents graduating a year, and it's getting going to be more and more as the residents new programs have started, and others are expanding, and so you're going to have more.
Right.
You're going to have about 1,200 graduates a year, and I think to have 10 transition from practice fellowships is not going to solve a problem
Sure.
if 25% of the residents feel insecure about operating by themselves.
Yeah.
That's going to leave you
I
a bit
imagined it.
short, like, for example, 300 short.
Sure. Well, I imagined it being somewhat of a test to see if this is an effective way of helping in that transition, and I suspect that more if it turns out to be a good model, that more such fellowships will emerge, or there'll be, in other words, more spots for that transitional fellowship.
That's true, but you could make the argument that it is basically a sixth year of residency,
Right.
and if you're going to have that, why don't you just do it and expand the programs, notwithstanding the issues we've already talked about. But because I think one of the issues is going to be how many people are going to want to take these fellows into their practices, and how many forget about wanting. I mean, how many potential places even are there to do this? I think that the initial program is probably starting out with a select group of people who've maybe had some experience or are known to be okay. But how are you going to expand this, and how are you going to make sure that these people really are getting a good education? And also, how about not being abused? It's there. I mean, not casting aspersions on anyone specifically, but I think that it is potentially abusable. Like, you tell the fellow, well, you're going to work all the weekends and most of the nights, and I'll be around if you need me, and I'm going to pay you $50,000. So that I think has I think it has to be, if it's going to be a fellowship, it's going to have to be regulated somehow, and the process is going to have to be like all fellowships, especially accredited fellowships, which is, what are you expecting from this, and how do you do it, and how do you vet the people who are running it to make sure that the fellow is not getting into a situation where he's either not going to learn anything or have to work too much or any of those kinds of issues. So, and I just can't see this. Can there be hundreds of surgeons out there who are just dying to have fellows around? I don't know. I don't really see it as the solution long term.
Sure. Okay.
Because it is in fact essentially adding a year of training at undoubtedly low pay. I don't know what the pay scale for the transition to practice fellows is, but it's certainly not going to be high, I wouldn't think.
Seems it
So,
would be
yeah.
disruptive too to the life of the person moving somewhere else for a year and then moving third place or for another job. In other words,
Well, I guess it. Yeah, I guess so. Except people are doing it right now. They're taking fellowships and going somewhere for a year or two, and then going to practice even in another place. I mean, it's not that much different from that, but it is uncharted waters. Let's face it. I mean, it'll be interesting to see what happens, what the feedback is from the first bunch of people who do it,
yeah,
as to whether they think it was worth it. And there's no way to know that until it ends and you ask them questions. Hopefully, I would assume that's going to be part of the deal. Is they're going to expect some answers from people as to how this worth it.
sure.
Do they feel more comfortable now after they've done it?
Yeah. Well, thanks, Dr. James Barone, for talking to us about I still can't say it. Thanks for talking to us. Appreciate your input.
About that thing we talked about. Yes, thank you. Bye.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.